Good evening, everyone. On behalf of Indian Association for Bronchology, I, Dr. Mehul Thakkar, welcome you all to the second webinar in the EBUS series. As we all know, this is an EBUS certification course, like we had a thoracoscopy certification course few months ago. Here we'll have a series of 10 webinars followed by one physical workshop in each zone of the country. At the end of all the 10 webinars and attending one physical workshop, people who have attended at least 8 out of 10 webinars for at least 90% of the times, we are keeping track of how much you have attended and the attendance in the physical hands-on workshop, which will be held in the zone of the country. People are eligible for this EBUS certification. We have done this so that everybody of us are equals. Everybody should have equal access to training and should get enough hands-on to start your own EBUS practice. Our last webinar was a super hit. We had the webinar on basics, and today we have record registrations, and I'm sure that will translate into a lot of attendance, and we have a star-studded panel with us. So without taking any much of your time, I would like to introduce our captain of the ship today, Dr. Amit Dameja. Can you put up the slide, please? Dr. Amit sir needs no introduction. He's a senior consultant in the Department of Chest Medicine in Sir Gangaram Hospital, New Delhi. He was the first in North India to start linear EBUS. So he has loads of experience in this area and he'll be captaining the ship today. He has recently started bronchoscopic thermal vapor ablation for COPD, the first center in North India. And he has multiple publications, multiple presentations and book chapters. Looking forward to hearing from you, sir. Sir, please take over. Sir, you are mute, sir.
Yeah, thank you, Mehul. And I must say, a wonderful initiative by the IAB. I still remember our days when we were training, we had no one to look forward to. Nobody in the country was doing EBUS, and we had to look around everywhere in the world. And I had to go to Denver. It was kind of difficult at that stage to survive and sustain ourselves at the stages of career that we were respectively in. But now things have changed. In the last 15 years, we have loads of people in India doing EBUS with good amount of experience, very good literature coming out of our country. And I must say that as far as the journey of interventional pulmonology and EBUS is concerned, we by far are the leaders in Southeast Asia. And I must congratulate IAB for this initiative, and I hope the youngsters will have very good time understanding each and every step in the setting up of an EBUS program, how to go about equipment, understanding the anatomy, and the subsequent upcoming lecture series. We'll be talking about EBUS and all the complications and talk about radials as well. So without much ado, I would be very, very privileged. I feel very, very privileged to introduce a very dear friend of mine, Dr. Bala Gumesh. Can I have the slide of Dr. Bala Gumesh, introductory slides? Dr. Bala, again, needs no introduction. He is a senior most faculty in CMC Vellore, professor and head, Department of Pulmonary Medicine, CMC. He has been a respiratory consultant, Shire Teaching Hospital, UK, 2018 to 2020. Memberships and fellowships in abundance, FICS, FCCP, FRCP, FRCS Glasgow, organizing chairman and secretary, publications, almost 100 plus journal articles and book chapters. He's been awarded KGR Murthy Oration Award for the year NAPCON 2020, ICMR Award for recognition and significant contribution for biomedical research, Srimati Kabul Sadbir Award for the year 2006. And keen areas of interest, a very good and very learned academician, and keen interest in bronchoscopy, lung cancer, and CPET. So without taking much of your time, I would hand over the stage to Dr. Bala Gumeshti for a wonderful, and I hope he has a wonderful talk, and all of us will have lots and lots to learn from him. And after the talk, we'll introduce the rest of the panelists and we'll taking on the questions as well. Thank you. Dr. Bala, please.
Thank you, Dr. Amit. Amit, I share the same feelings. He's a close friend of mine. I'm grateful to the Indian Association of Bronchology, Dr. Amit Nene, for this initiative and giving this platform on EBUS. I'll share my screen. Okay. Is the slide visible? Pardon?
Yes, sir. We can.
I unchecked it. Okay. So the topic is mediastinal anatomy, stations, the ultrasound characteristics of mediastinal lymph node. As Dr. Amit told, he had to go to Denmark to learn EBUS. It was the year 2008. I went to Heidelberg, Germany to learn endobronchial ultrasound. And EBUS was just starting to be introduced in India. I learned in Dr. Felix Hertz's center, EBUS. And while I was there, I wrote the review article which was published in Lung India in the year 2009, a new innovation in bronchoscopy. And surely it has become the most important breakthrough in the field of pulmonary medicine, and it is essential for any high volume respiratory practice. If you look at the EBUS training program curriculum published by the European Respiratory Society, and the first section is on pre-procedure. And then in the pre-procedure section, the major part is anatomy. So anatomy is boring. We all studied it without it. I mean, many of us studied it without interest during our MBBS days, but it is crucial for doing EBUS successfully and confidently. Why we need to know mediastinal anatomy? We need to know whether EBUS is feasible or justifiable in a given patient. To understand how safe it is to do EBUS in this patient, we need to understand the relationship between CT or PET scan and the EBUS image, and we need to do a staging for lung cancer. In good old MBBS days, this is what mediastinum consists of, superior mediastinum, and then the inferior mediastinum is divided into anterior, middle, and posterior mediastinum. But we need to have a much more detailed anatomy as a bronchoscopist and while doing EBUS. The lymph node classification in the TNM staging is N1, N2, and N3. What does N1 mean? It's very simple. Here you can see that there is a tumor in the right lung. A lymph node metastasis which is confined to the visceral pleural lining is called N1 lymph node. So that starts from the hilar lymph node and then it goes to the intrabronchial lymph node. What is N2 lymph node? Here there is a tumor in the left lung. Any lymph node which has been involved in metastasis beyond the visceral pleural lining, ipsilateral mediastinal lymph nodes, N2, including the subcarinal, it's called N2 lymph nodes. What is N3? If the tumor is on the right side, a contralateral mediastinal lymph nodes on the opposite side, and any supraclavicular lymph node, and becomes an N3 node. So these are the basic N1, N2, N3 of the TNM staging. A little more in detail, International Association of Study on Lung Cancer project, they introduced a system in which they classified lymph nodes 1 to 14. And they classified as superior mediastinal lymph node, inferior mediastinal lymph node, and N1 nodes. The highest superior mediastinum included the highest mediastinum, upper paratracheal, prevascular retrotracheal, and the lower paratracheal. The inferior mediastinum, subcarinal, paraesophageal, and pulmonary ligament, and the N1 nodes, 10, 11, 12, 13, 14. And it is easy to remember that N1 nodes are in double digits. 10 onwards, the lymph nodes are N1 nodes. 1 to 9 are N2 nodes, and but it has to be in the ipsilateral to the lung tumor, and it is easy to remember. The station 3 lymph nodes are of two types. It can be pre retrotracheal or prevascular, and the station 5 and 6 are subaortic and para-aortic. We need to have a thorough understanding of a relationship of great vessels and the major structures in the mediastinum for us to understand where these lymph nodes are situated. I will go one by one. So this is the esophagus in the yellow structure and the tracheobronchial tree in front of esophagus. Anterior to the trachea is the superior vena cava, which is formed by joining of the left brachiocephalic vein and the right brachiocephalic vein. And this junction is at the lower trachea on the right lateral wall or anterolateral wall. At the middle of the superior vena cava, it is joined by the azygos vein, and subsequently SVC drains into the right atrium. And this anatomy is important. Anterior to the carina is the ascending aorta, which arches onto the left side of the lower trachea, goes behind the left main bronchus, and goes down as the descending aorta. There are three major branches of the arch of aorta: brachiocephalic artery, left common carotid, and the left subclavian, which goes between the trachea and the left brachiocephalic vein. In addition is the pulmonary trunk with the right pulmonary artery and the left pulmonary artery. So these are the major structures in the mediastinum, and we need to understand where the lymph nodes are situated in relation to these structures. So when we do a linear EBUS, there are 6 major stations from which you can look at or describe the lymph nodes. It doesn't mean that you cannot look from anywhere else, but to understand the anatomy for us to remember, we need to remember these major stations. One is the upper trachea, lower trachea, right main bronchus, right intermediate bronchus, proximal left main bronchus, and the distal left main bronchus. And from here, we can look at the various structures and the lymph node stations. So not only that, we can use EBUS to study the mediastinum and sample the mediastinum. We can use the endoscopic ultrasound or even use the EBUS scope itself in the esophagus, introduce it in the esophagus. It's called USG procedure. And what are the lymph nodes which can be seen by EBUS and EUS depends on the anatomy. So here, the purple lymph nodes, which are inside the visceral pleural lining, 10, 11, 12, all these can be sampled or seen only by EBUS. The lymph nodes in green, 2R, 2L, 4R, 4L, 7, and lung tumors, depending on where they are located, can either be sampled by EBUS or EUS. But again, it depends on a thorough understanding and study of the CT scan. Lymph nodes 8, 9, paraesophageal and pulmonary ligament nodes can only be sampled by the scope in the esophagus. And if you are very expert, you can introduce the EUS scope into the abdomen and sample the other things which is beyond the scope of this talk. Another important thing we need to remember is the image which we see in EBUS is either in the sagittal plane or coronal plane, because the EBUS is introduced like this and the field of vision is from superior to inferior, and you are not looking at a transverse plane or an axial cross section. So usual CT scans or PET scan is a axial image or transverse plane looking from below. But EBUS, it is different. You are looking at the mediastinum in a sagittal plane or a coronal plane. And then you say it is which station, it is, which location it is situated by the clock position 3, 6, 9, and 12. So this is an example of a patient in which we did the procedure last week. You can see bilateral hilar enlargement, right lower paratracheal stripe is widened. We'll look at the CT scan and try to understand where the lymph nodes are supposed to be located. Okay. We are from the trachea, upper trachea in the lower part of the neck. We are going into the upper mediastinum. You can see the branches of the arch of aorta appearing here, and the left brachiocephalic vein appearing here, the right brachiocephalic vein, which is taking up the contrast. And this is the location for the 2R and 2L lymph node, upper trachea. This is left brachiocephalic, right brachiocephalic, and the three branches of the aorta. As we go down, it is the paratracheal location, lower paratracheal location, or right lower paratracheal 4R on the right side. And as we go down, it is the 4L on the left side. And this is the para-aortic station 6 lymph node beyond the arch of aorta. And here, SVC is being joined by the azygos. This is the azygos SVC confluence, and that's an important landmark to differentiating 4R from the right hilar lymph node. This is the 4R location, and this is the right hilar or the 10R location. And that is very crucial because it is one lymph node is N1 and the other lymph node is N2. This is the subcarinal lymph node, which is easily seen. And on either side, 11R, as well as the 11L lymph node. 11R lymph node and the 11L lymph node on either side. So this is the transverse or the axial plane. We will look at the same patient's scan in the coronal plane, which is more in alignment with the EBUS image. Okay, this is the upper trachea, cervical part of the trachea. We are coming into the superior mediastinum. This is the, on either side is the upper paratracheal 2R, 2L station. This is the lower paratracheal 4R location, and this is the 10R location. And here is the 4L location between the aortic arch and the left pulmonary artery, 4L lymph node, and laterally is the station 5 and 6. This is the subcarinal triangle, subcarinal area where the station 7 lymph node. This is 11R on the right side and 11L on the left side. And if you go down, you can see the paraesophageal lymph nodes. Another important thing is you need to have a standard position of the EBUS probe. You can, on the click button, you can change it from as if the needle is coming from the left side or from the down. You can all do it, but the standard positioning is the probe and the needle coming from the right upper quadrant of your screen of your monitor. To understand the correlation between the CT scan and the EBUS image, shown two stations. This is the left lower paratracheal 4L location, ascending aorta, left pulmonary artery, and the 4L station. And this is the coronal image, aorta, left pulmonary artery, and in between is the 4L station, and the EBUS scope probe is at this position. You just flip this image, and then your image of the CT scan will look like this. This is the field of the vision of the EBUS scope. And then this will correlate to the EBUS image of aorta here left pulmonary artery, and in between is the foral lymph node, and distally will be the station 5 and 6. So you flip the coronal image, and that will correlate with your EBUS image. Similarly, subcarinal station 7, axial section, and this is the coronal section. So EBUS scope you keep either on the right or the left main bronchus, and then look medially, and your picture will look like that. Needle coming from here, and then you have the subcarinal lymph node, and you have distally, you have the left atrium, which is in the CT scan, it is looking like this. Okay, and then I will go through some of the important stations and the borders of the stations. 2R, it extends from the upper apex of the lung to the upper intersection of the left brachiocephalic vein to the joining of the SVC at the level of trachea. And you keep the scope at the upper trachea, at the 4th, 5th tracheal rings, and you look laterally towards the 3 o'clock position. At the 2L lymph node, you keep the scope at the same position and you look at 9 o'clock position. And here the lower border is in the upper border of the aorta. 4R lymph node, it extends from the margin of the left brachiocephalic vein and extends to the lower border of the azygos vein. You keep the scope in the lower trachea 1 or 2 rings above the carina, and either you look anteriorly at 12 o'clock or 3 o'clock. So any of these positions you can see the 4R lymph node. And 10R is beyond the azygos vein, and that differentiation is very crucial to differentiate between the N1 and N2 lymph node. Station 7 is very simple. It is subcarinal region bounded by the right main bronchus as well as the right intermediate bronchus, and on the right side as well as the left main bronchus. 11R is between the upper or the upper lobe and the bronchus intermedius, or it can be an inferior location of the 11R lobe between the middle and the lower lobe on the right side. Similarly, on the left side as well, you can look at the 11L lymph node. So the next important topic is the characteristics or sonographic characteristics of the lymph node. And this has to be included in the EBUS report. Why it is important, you can have an idea whether the lymph node is going to be benign or malignant based on these characteristics. But based on this characteristic alone, you cannot say that I will not sample the lymph node. You have to sample, but it is important that you document it, and it may help in further refining how much sample or which lymph node you should concentrate on taking samples if there is multiple lymph nodes which have varying characteristics. Some of the important characteristics are size of lymph node, short axis, in which if it is more than 1 centimeter, you can consider that it is likely to be malignant. Another important aspect is the size of the shape of the lymph node. You can have an objective parameter by the long axis, short axis ratio. An oval lymph node in which the ratio is more than or equal to 1.5 is likely to be benign. If it is round, then it is likely to be malignant. If it is heterogeneous echo texture, it is likely to be malignant, but however, tuberculosis can also be heterogeneous. Homogeneous is likely to be benign. Margins, if it is distinct, it is likely to be benign. Malignant has indistinct margins. Malignant lymph nodes have high vasculature. So you put press the color Doppler on and see for vasculature, and it may be rich in malignant lymph node. If the lymph nodes coalesce with each other with indistinct margins, it's likely to be malignant. Necrosis, if it is present, it can be either due to malignancy or tuberculosis. Central hydra structures are typically preserved in benign lymph node, and they appear as a hyperechoic linear streak at the center of the lymph node, and they contain connective tissue as well as small blood vessels, and they are preserved in benign lymph node. And if you have facility to do elastography, a blue elastography pattern is more suggestive of malignant lymph node. Any one of these characteristics have limited value in diagnosis of predicting as benign or malignancy. But if you use a combination of factors, according to this study, the accuracy goes beyond 80%. However, having said that, whatever the characteristics of lymph node, you have to sample it for confirmation. You cannot rely only on the echogenic characteristics. So in conclusion, understanding mediastinal anatomy is very important. It is crucial for performing an EBUS successfully as well as safely, and it helps in the diagnosis of not only mediastinal lymph node, even other mediastinal diseases. Thank you for your kind listening.
Thank you. Thank you, Dr. Bala. An excellent talk as always. I thoroughly enjoyed it. It was a very good revision, I guess, for all of us. And for the beginners, it was very, very exhaustive, starting from the images that we have seen in the first year of MBBS, going up to all the CT scans we did in the third year and fourth years, and of course, going down to advancements in bronchoscopy and correlating each and every aspect of anatomy as compared to what we see on an X-ray, as compared to how we see on a CT, going on to do the EBUS as a real-time procedure. I don't think we could have had a better speaker than you. Thanks, and hats off to you, Dr. Bala. So now it is my proud, very pleasant duty to introduce the rest of the panelists. We'll give Dr. Bala some rest so that he can relax for a while. And I'll just, in the meanwhile, introduce other panelists. Can I have the introduction slides on the monitor, please?
My slides introduction.
Can you go to the next one, please?
Yes, sir.
Yeah. So a very good evening and welcome to Dr. Rennie Davis from Head of the Department of DM Pulmonary Medicine, Vice Principal, Amla Institute of Medical Sciences, Thrissur, Kerala. And we've had a wonderful conference which you guys hosted. BronchoCon went on very well, and many, many congratulations to you for all the hard work that you put in. Very warm welcome to you, Dr. Dennis. He has special interest in interventional pulmonology and critical care, international presentations, attended various national and international conferences, poster presentations in World Association of Bronchology, 2 papers in ERS London 2016, and a DM examiner since 2020. Special interest in IP, rigid bronchothoracoscopy, allergy and immunology, special training in interventional pulmonology, rigid bronchoscopy, allergy and immunology, lung transplant and cryobiopsies, and BTVA from the best centers in the world, 50 international and national publications to his credit, and many awards, including University Scholarship 1992 to 1997, Young Scientist Award, Young Pulmonologist Award at PulmoCon 2013, Best Papers at CMC Law 2005, Gulf Thoracic Society, Best Doctors of South India, and of course, DB Past Pupil GEM Award 2023. A very warm welcome to you, Dr. Rennies, and we'll be taking on, we'll be expecting some difficult answers, difficult questions we'll put up to you, and we expect excellent answers and follow up.
Welcome. Thank you, Dr.
Thank you, Dr. Rennies. Thank you, Dr. Rennies. And the next panelist we have is Dr. Mansi Gupta. Mansi had done his DNB, respiratory diseases, and went on to do it DM pulmonary medicine, European diploma in adult respiratory medicine, and currently she is an associate professor, Department of Pulmonary Medicine, SGPGIMS Lucknow, awarded Best DM Fellow, Gold Medal, Pulmonary Critical Care and Sleep Medicine, Vardhaman Mahavir Medical College and Safdarjung Hospital, Delhi. Total professional experience of almost more than 14 years, over 60 publications and book chapters, and areas of interest include EBUS guided procedures, mechanical ventilation, ILDs, difficult to treat obstructive airway diseases. A very warm welcome to you, Dr. Mansi. A very good evening, and we hope of a very fruitful interaction between us. And of course, we'll be taking up questions as and how they pop up on the screen, and I get a prompt from the organizers. We'll be interrupting you in between as well.
Thank you, sir. Thank you.
Very warm welcome, Dr. Mansi. Next panelist, we have Dr. Shyam Krishan, MBBS, MD, MBBS, DNB, European Diploma in Adult Respiratory Medicine. He's a lead consultant presently in intervention and critical pulmonology, Department of Pulmonary Medicine, CMRI, BM, Birla Hospital, Kolkata. Faculty Diplomate of National Board Respiratory Medicine, co-founder of Vayu Education Initiative, over 50 publications and book chapters, keen areas of interest, again, interventional pulmonology, ILD, obstructive airway disease, and of course, upcoming AI. We want to see more and more of AI venturing into our own living rooms and bedrooms soon. So welcome, and we have exciting future ahead with people of Dr. Shyam's caliber and people in medicine going on for amalgamation of medicine and AI. We're going to have an excellent lead ahead. Very warm welcome, Dr. Shah. I hope you reached home.
Yeah, I reached home.
Oh, yes. You were still stuck in traffic last week when we spoke to you. Very well. Very warm welcome, Dr. Shyam. And the fourth panelist for the day, can we have the next slide again, please? Yeah. Very warm welcome to Dr. Anshu Punjabi, who's an assistant professor, Department of Pulmonary Medicine, Tata Memorial Hospital, Mumbai. She has done an MD, DNB in Pulmonary Medicine, MRCP UK, and EDRM Italy again. Fellow in Respiratory Medicine, Norfolk and Norwich Hospitals, Norwich University, UK. Fellow IP and Thoracic Oncology, again from UK. More than 20 publications to her credit. Best Oral Presentation Award in BTOG 2020 and gold medalist in her MD. And areas of interest, thoracic oncology and interventional pulmonology. So all the panelists and the speakers share same interests and are on the same platform, and we are ready to take on the questions. I have my own list of questions which I'll be talking about. And in between, in case there is any interesting question from the audience, you are more than welcome to send a questions to us. In case they're not included in our list, we'll be more than happy to incorporate, because the ultimate aim of this 1.5 hours presentation would be to enhance the knowledge of people who really want to learn. We're not there to kind of talk up and post about our own achievements. We are here to teach you. In case anything which you want specifically to be answered by any specific person, please feel free and be connected with us. Thank you so much. So going on to the list of questions, the first question to you, Dr. N, is we all know that EBUS was invented in the West, and of course the primary aim was to kind of look at mediastinal lymph node stations and to stage CA lung. But in our country, we see a very different perspective and a different set of patients for which we are doing EBUS. And I would like to understand from you, what are the most common diseases that one encounters related to the mediastinum, which we see in our country's parlance, and what are the most important modalities used for diagnosing mediastinal pathologies in our country?
Yeah, thank you, Dr. Amit, for such a kind question. Nice question. The mediastinum as such, we commonly come across the lymph nodes in the mediastinum. Sometimes, rarely, some the thymomas or lymphomas, some cysts, the bronchogenic cysts, and mostly the lung malignancy or benign or malignant ones. Benign ones usually can be some infections, kind of tuberculosis or fungal. Then it can be sarcoid lesion or lymph node. Then lung cancers. These are the most commonly seen things, and also sometimes infections like mediastinitis and all. So that's the kind of diseases which we commonly come across. And apart from EBUS, today's topic, we do have the X-ray, CT, MRI, then PET CT scan, where you can have to know the metabolic activity of the lesion, whether it's a tumor or lymph node, or whether it's a cyst or lymphomas and all the stuff. So and then the newer technologies which can be incorporated into our EBUS, like maybe the Doppler or elastography or our AI, all this may come into play in the future also.
And according to you, what will be the most important diagnostic investigation? Do you still do mediastinoscopies at your center, or the surgeons have probably forgotten how to do mediastinoscopy since the EBUS have come in?
Yeah, I mean, these days we are more interventional. The pulmonologists are more interventional, and the surgeons are more conservative. And also the mediastinoscopy, I forgot to tell you about. Sorry for that. The mediastinoscopy basically in the initial era before the EBUS era, it was performed by the CTVS people very rarely, because getting intrusion into a mediastinal structure for a diagnosis, it was too hard for the patients. And luckily, of the EBUS, after the EBUS era, we are doing the mediastinoscopy is most of the time it's out of way, and maybe we are getting the diagnosis with our EBUS guided FNACs.
Dr. Mansi, if I can ask you, what will be the most common indications for which you would do an EBUS on a patient at your center?
So, the most common indications that we perform EBUS for is in India, we deal with a lot of tuberculosis, and the chronic granulomatous diseases, particularly, there is a lot of confusion going on regarding the diagnosis of TB versus sarcoid. So that is the primary indication in our setup also. The other thing is we do lymph node sampling for staging of lung cancers, which we are also doing, and also for proving metastatic lymph nodes in cases of extrathoracic malignancies. Commonly, we are sent those referrals. Then other thing is ruling out infections in patients who are on immunosuppression and they need some step up on immunosuppression and they are having low grade, fever or something. So many a times we have found out atypical organisms, again, infections tend to dominate the list of lymph node sampling. These are the most common uses. Apart from that, sometimes here and there we have tried aspiration of abscesses and bronchogenesis, but these are not the common indications that they don't want to say that we perform that very regularly. We have been able to visualize pulmonary artery thrombus also in a rare occasion. So these are some uncommon, but they are not particularly the uses of indications of EBUS. Mainly, we are trying to sample mediastinal lesions or particularly lymph nodes which are abutting the major airways and which fall into the sonographic image of the linear EBUS. This is the main important thing.
So I guess all of us would agree that in India, the predominant pathologies that we will encounter when we say sort out our patients, more than 50% of our work would be constituting granulomatous pathologies. Depending upon where we are practicing, it could be sarcoid or tuberculosis. In our center, as well as our own data plus data from other big centers in the country, we see that almost just 20-25% of our work would be constituting staging of CA lung, because most of the patients, by the time they come to a physician or a surgeon, are already stage 3 above, and they would not need any mediastinal staging. But for people who would be qualifying for any kind of a surgery for CA lung, it would constitute about 20% of our work. Dr. Anshu, I can understand you would differ on that because you work in a center where dedicatedly for lung cancer. But for general multi-specialty hospitals, this is the data that we have kind of tabulated from all the big centers in the country. And of course, then you would have lots of lymph nodes you would sample thinking that they might be tubercular, they might be sarcoid, but they can just be reactive lymphadenopathy. Another very important thing which I would like to bring out is we see patients of CLDs, CKDs, cardiac failures who are overloaded. So we should not be jumping onto doing an EBUS in all these cases just because we are seeing a lymph node in the mediastinal. We should understand that lymph nodes are actually clearing off the fluid from the system. So in case the lungs are overloaded, in case the vasculature is, in case the vascularity is more, or in case there is fluid overload, that lymph nodes tend to enlarge. And in many of these patients with systemic problems like CLD, CKD, and a cardiac decompensation, you would have lymph nodes which will be seen on a CT scan. When you put an ultrasound, you will be able to see a very different image from what you see in a pathological lymph node. You would see a more echogenic, a white, homogeneous structure. And when you aspirate, actually we've aspirated, very thin fluid, like, serum from them. And they actually are not lymph nodes which need to be sampled. So we need to be selecting our patients carefully. Only when we are suspecting a pathology which might justify the use or doing this procedure in a patient, we should do that. So most commonly in our country, we'll do it for mediastinal, benign mediastinal pathologies. Then we go on to malignancy, and then we categorize. We have hordes and lots of, reactive lymph nodes and rare disorders like fungal and, aspergillus, mucor, everything which is, now we are seeing many many bacterial disorders which are manifesting as lymph node enlargement as well. So thank you so much, Dr. Mansi. After all the indications, as judicious, very cautious users of this particular equipment, Dr. Sham, what would be your take, and how would you, what would be the most important contraindications? When will you be scared of doing an EBUS in a patient? I know it is a relative contraindication, but I would just like you to take us through all the contraindications of doing an EBUS in a critical patient.
So contraindications, actually, there's the usual long list for contraindication for bronchoscopy and EBUS. They're mostly similar.
Yeah.
But for EBUS, I would suggest, my personal experience has always been patients. You need to be very careful with selecting patients who got cardiac issues, especially irregular cardiac rhythms, which is uncontrolled. A recent MI. I actually lost a patient just. So the patient was referred to me by a cardiothoracic surgeon for fitness, had a severe aortic stenosis, and you need to be very cautious while sedating these patients. The slight drop in BP, you can never get the forward flow. The patient actually went into cardiac arrest. Just the first dose of mild midas and fenta, which was given, and we lost the patient. So that was I actually, my ears, the red flags all go up whenever I see a patient with valvular heart disease or some cardiac condition. And the related contraindications could always be, refractory hypoxemia. You always need to be careful when you sample patients with ILDs or, with severe pulmonary hypertension. You need to optimize them and then probably go ahead. Blood thinners obviously is a relative contraindication. You should always assess the safety. So if it's a recent cardiac stent being placed and the patient is on dual antiplatelets, obviously the cardiologist wouldn't be happy stopping those antiplatelets. So then you need to negotiate with the cardiologist as to what are the safety parameter. You bridge the patient with heparin during that time and then go ahead with the procedure. If it is so, if they need to establish a diagnosis is urgent. So I would say cardiac parameters, the cardiac conditions, basically a recent MI, irregular cardiac rhythms, raised pulmonary pressures, pulmonary artery pressures, and refractory hypoxemia. They are the more or less contraindications in my book, or relative contraindications.
And your take on difficult airways when you're doing an EBUS?
So difficult airways is, but then rarely you get a patient where you have, a stenosis and then you need to pass the thing. You need to take care of the stenosis first, obviously. Or you can do it as once you dilate it with a rigid, and then you can go ahead and then do this simultaneous EBUS procedure in those patients. But that's very rare when you come across, or patient with, so I had one case where the patient had a fall because of a brain mets, and the face was disfigured.
broken
You had
jaw.
to do a nasotracheal intubation with the EBUS. So, but they are very rare, case scenarios where you would experience these. So you need to.
In cases where you have a maxillofacial surgery, or in cases where you had radiotherapy, in those cases, mouth opening can actually be very difficult. So you won't even have space enough to put in a pediatric bite block. So in those cases, I would suggest that in case you have a tracheostomy, don't pass the scope through the tracheostomy, take out the tracheostomy, and if the tracheostomy stoma has kind of epithelialized, you can just take out the tracheostomy and put in the scope through the stoma rather than the tracheostomy, because tracheostomy would have a very sharp angle for the scope to bend, and you might break the fibers. Nasal intubation again is possible. We have done a couple of cases only when the oral intubation is not possible because of any prior surgery or radiotherapy or difficult mouth opening in cases which are prohibitive. But nasal, of course, you have to see the roominess of the nasal passages, make sure that you do not injure or cause any bleeding. You should have adequate platelet numbers when you're doing a nasal cannulation as well. So definitely all the contraindications for bronchoscopy will be contraindications for EBUS as well. And we need to be very, very cautious in patients who are on antiplatelets, people who have a poor cardiac reserve, people who have arrhythmias, people who have a poor respiratory status because of underlying pulmonary problem or an underlying systemic problem, which would kind of put the patient in jeopardy during the procedure as well. Dr. Anshu, what would be, since you work in a thoracic oncology center, what would be your take? How would you rate EBUS as far as other techniques in taking samples from mediastinal, from the lung masses and mediastinal masses as compared to other surgical techniques?
Yeah, good evening, everyone. Good evening, everyone. Sir, am I audible?
Yeah, Anshu, please go on.
Yeah. So, yes, anything which can be hugging the airway or the esophagus can be accessed by the EBUS or by even doing EUSB FNA if you are well versed with the technique. So a lot of times you do have some central tumors which are causing external compression on the major bronchi. But if you put in your linear scope, you can actually see the tumor and then sample it under vision. Also, if we look at other mediastinal masses like thymomas or sometimes lymphomas presenting with big mediastinal areas or even fibrosing mediastinitis. So as long as we can access it through the airways or the esophagus in a safe way, you can do it. We have had rare cases of angiocentric, unicentric Castleman's disease and fibrosing mediastinitis for which we have done EBUS. And there are this is a very rare finding, I would say, in so many years that we have been doing EBUS. I would count them as single digits where we had to do for such rare cases. There are case reports of pulmonary sarcomas which can be diagnosed and even sampling of the mediastinal pleura in cases of mesotheliomas if required. But these are again very scanty case reports which are available. There is not a lot of literature. So you do it only if that is the best way to get the diagnosis in the least invasive possible way and is safe for the patient.
And as far as the yield is concerned, are you happy?
Yes, so we do use, if we are suspecting fibrosing mediastinitis, we would go ahead with a Procore or an Acquire needle. And for certain lymphoma cases, we do try using a 19 gauge needle for these cases. So the yield is good. In few cases, you may have to repeat the procedure, but we do have rows. So we sometimes know if our sampling is inadequate and we can change the needle or take a bigger core biopsy needle as well.
Well, as far as data goes, when we are targeting mediastinal masses, primarily pulmonary masses through EBUS, the yield can be as high as 97 to 98%. There is very little chance that you'll be missing a mass. As far as mediastinal mass is concerned, the yield definitely will depend on the etiology. In case you are dealing with lymphoma, the yield of an FNAC is definitely going to be less. You would need a larger biopsy for that. And of course, as far as, and what about any experience of restaging of mediastinum? How comfortable would you be doing EBUS for restaging of mediastinum?
We do restaging for EBUS after they have received NACT. Nowadays, a lot of patients are also receiving NACT IO. What we find is that sometimes they are more harder to puncture than normal. And especially with IO, you see a slightly higher bleeding that you would see with normal lymph nodes. If you look at the data of comparing mediastinoscopy to restaging EBUS, actually both are equivocal. So we do it on a case-to-case basis, only if it is a new lymph node has come up or something. Otherwise, our surgeons are more than happy to do a mediastinoscopy and then proceed with the surgery in the same setting.
In the same setting, yes. Yes, that's going to be a very good approach. In fact, if you can do both, we can prepare the patient for both procedures in the same sitting, and you have a frozen of the mediastinal sample taken care of by the pathologist. Within half an hour, you'll get the answer. Yeah. Thank you so much. Just going to be a couple of questions, which will be a repetition of what Dr. Bala has talked about. But I was told by IAB that a couple of people will be joining us a little late, so they would want certain aspects of the talk also covered in the question answers. So my question to you, Dr. Bala, I know it's going to be a repetition. which lymph node stations on EBUS and what lymph node station can be accessed via EUS?
So whatever is the basic principle is whatever is adjacent to trachea and the bronchi can be assessed by EBUS. Whatever is adjacent to esophagus can be assessed by the EUS. So the lymph nodes which are common to both, the typical example is the station 7 or the subcarinal lymph node you can access by both. So sometimes a patient is quite sick, is already on oxygen. We don't want to put a EBUS scope into the trachea. You can put it in the esophagus and patient continues to breathe normally, and you can easily sample the subcarinal lymph node. Some lymph nodes can be exclusively accessed only by the EBUS, which are the N1 lymph nodes, which are 10R, 11R, 10L, and 11L. Some lymph nodes are exclusively accessed only by the EUS scope, the paraesophageal and the pulmonary ligament nodes. The station 5 and 6 are difficult to access by both the nodes, both the scopes, EBUS as well as USB, but with some change in the direction or the alignment of your EUS scope, some people can access the station 5 through the esophagus, but otherwise you have to use the transvascular route through one of the scopes for assessing stations 5 and 6. So these are the basic principles of using EBUS as well as USB for different stations of lymph nodes.
Great. And one question from the audience, Dr. Bala. How would you kind of rate the sensitivity and specificity of EBUS FNAC as compared to other modalities, primarily radiographic modalities like CT and PET, when we are looking at definitive yes or no as far as staging the mediastinum is concerned?
So that's a very good question. So what if you already got a diagnosis and PET shows uptake, enlarged lymph nodes, and PET shows uptake in the mediastinum? So can we believe that it is metastasis? Studies have shown that no. These PET scans can show uptake even in other conditions due to reactive lymphadenopathy, or could be unrelated tuberculosis or sarcoid in a background of malignancy. So you cannot fully believe that PET uptake means that it is metastasis. You have to have a sampling proof to prove that it is malignant. Even if it is negative, sometimes, especially the small lymph nodes, the size lymph nodes less than 1 centimeter, the PET sensitivity is low. And you cannot say that, okay, because it is PET negative, these are likely to be not involved by malignancy. You cannot tell that. You have to sample and prove. So as compared to PET scan, the EBUS sensitivity and accuracy is much, much higher.
So the accuracy of CT scan, we normally categorize less than 1 centimeter to be the cutoff for a CT scan. Almost 30% of lymph nodes less than 1 centimeter on a CT scan will ultimately turn out to be having malignancy. And PET can be false positive in 30%, and PET can be false negative in up to 10% of cases. So we definitely would need to take a jab as far as possible and not rely primarily on radiological or PET uptake of the lymph node to determine whether it is benign or malignant. And Dr. Ennis, we all use color Doppler and power Doppler very, very frequently. Just let us know the difference between the two and how frequently it is used to kind of categorize the lymph nodes from benign to malignant, and how frequently do you use it to kind of select a site from which to take a biopsy or FNAC from?
Yeah, that's a nice question. The way I use Doppler usually to know the vascularity of that tumor, and where are the vessels to know about it, about those vessels within that lymph node or the tumor, so that I can have a better placement of the needle and I can jab safely without causing much blood getting into the needle. So that's how I go about not for better tissue characterization, but rather than to know the vascularity of the area and to know the velocity and the direction of the flow. I can use as you have told, the colored power or spectral Dopplers, and then identify an area where there is no much bleed can occur. And post procedure also, I may look into the Dopplers to know what is happening over there after taking out the tissue. So whether there is any bleed, and we can know it from the needle itself, but still we can have a colored Doppler mode after the procedure.
Thank you. And another question just popped up. How would you rate using balloon, for better coupling of EBUS as compared to not using a balloon? How would you do it?
Yeah, initially when I started with the EBUS, I was using the balloon. That gives more approximation to the airway wall, and the node characterization is better with the balloon if you use. But later on, after doing a lot of EBUS, I started not using the balloon. I don't know what's the reason, because sometimes it may cause some breaking, and then I'm not so fond of balloon. Without balloon itself, maybe we are on the learning curve, and we have learned a lot after doing so much of EBUS. So we just put apart the balloon these days I'm going mostly I'm going without the balloon. And sometimes it depends on the locations. Sometimes the difficult locations for the convex prop to reach the airway or touch the airway wall. If we use the balloon, it should be the proper image we get it, and it's better always in those areas like a 2R or a 2L, or sometimes in a 4L. Sometimes you get to know more about the vessels and all. You want to know more about the vessels. Better we use the balloon and then go forward.
So I guess for beginners, you would rather use a balloon because you would cause less damage to the scope, and it will be easier for you to access more angulated areas or more straight areas. Angulated areas are in fact going to be easy to reach with an EBUS. For a straighter airway, you would need a balloon so that you don't have to angulate the scope very much. But later on, during your own practice and how you find it comfortable, as far as image is concerned, as far as the yield is concerned, with or without a balloon would not really make a difference if you are experienced enough. Thank you so much. So Dr. Mansi, I know it's again going to be a repetition, but when I started, when I saw EBUS first time in US with Dr. Musani in 2007-8, I actually got perplexed, by the various landmarks he used to tell me. He used to give me a list of all the vessels and all the area which we were seeing in the mediastinum. For me, it was like, Chinese. I really had no idea what he's talking about. So as a beginner, when you start setting up, or when you go to learn at a particular place, what are the various landmarks, or what are the key anatomical locations you should have in mind before you start even seeing an EBUS, so that you can have a whereabout as to where the scope is? So what are the most important landmarks that you will look for in the most simplest of ways for a beginner to do an EBUS?
So, Dr. Bala Mangesh has already covered in detail about the most
I know we're going
important
to have
ones, but
some repetition, Mansi.
yeah. So the thing is that most importantly, as soon as you enter the trachea, the upper trachea is the main thing that you have to visualize. And then there are certain veins. You should be aware of the location of superior vena cava, because that is going to mark the boundary of your upper paratracheal lymph node versus a lower paratracheal lymph node. Then when we scan down, so idea is basically go from right to left. So when you start scanning in the upper airway, keeping superior vena cava in mind, you see the upper paratracheal lymph node on the right side, which is a 2R. Then you go down to the 4R station, which the inferior boundary will be marked by the azygous vein. And then as soon as you enter the right main bronchus, and you can see the azygous vein, the moment you go to the caudal marginal, you cross the azygous vein, you see the 10R station. Then immediately you try to localize, that is your hilar station, right hilar station. Then after that, you try and visualize the 11R station. Possibly it's easy to localize because it's sitting on the bifurcation of bronchus intermedius and the right upper lobe bronchus. then these are the main landmarks that you see on the right side, and immediately then you start and see the subcarinal station, which is very easy to, because we all know what is carina when we are doing basic bronchoscopies. So either on the right side or on the left side, you can try and oppose your scope from either right side or the left side and try to locate the subcarinal station. In the subcarinal station, what you'll be able to see is the boundaries will be the bronchial bronchi on the main bronchi on the either side, and you'll be able to see left atrium sometimes, which is actually pulsating quite hard, and the lymph node is visible against it. So that's how you locate, visualize the subcarinal. Then you move on to the left side, and similarly, at the bifurcation, you can see 11L, where you have your secondary carina, your left upper lobe is branching out, and you have your lower lobe bronchus. So when you try and oppose your scope there, you can have your 11L station. Then moving up, when you're coming back and you're trying to locate your 10L, again, 10L is easy to locate. As you are sliding your scope up, you'll be able to see the pulmonary artery, and beyond it, you'll be having a 10L station. Now, very interesting that Mickey Mouse sign, which is described as for 4L station, which is where you'll be able to see a lymph node sitting just between the aorta and the left pulmonary artery. That is typically known as the Mickey Mouse sign in EBUS, and you can see the 4L station there. And as you again slide back towards the upper trachea on the left side, you can see that there is a 2L station right in the upper part of the trachea. So these are basically the great veins that I said was superior vena cava, azygous vein, and then you should know about the location of pulmonary artery on the left side, and aorta, and then subcarinal is easy to locate. So these are the main things that I look for, and as a beginner, I think that's sufficient to know about these ones. Then as you move on in your learning curve, you may explore further with thinner scopes. You can go down to the intrapulmonary nodes as well.
So the most common landmarks as far as bronchoscopic visualization is concerned would be the carina, RC1 and LC1. That's what all of us clearly identify doing bronchoscopies. And the most important vessels on the right side will be brachiocephalic, superior vena cava, azygous. On the left side, it is going to be aorta and the pulmonary artery. So going on the right, you have three vessels to remember: brachiocephalic, SPC, and azygous, which will give you a differentiation between 2, 4, and 10. And of course, on the left side, the aorta and the pulmonary artery. Anything above the aorta is going to be 2L. Anything between the aorta and the pulmonary artery is going to be 4L, and distal to it will be 10L. So these are the most important things which should be looking at. And of course, Dr. Balamukesh had an excellent video showing us all these stations in a CT scan in a running video, as well as the flipping over that he did was again amazing for us to understand and for beginners to orient themselves, because what you see in a CT is again axial view. What you're doing in a bronchoscopy is going to be a sagittal or a coronal view. So you need to kind of have a 3D image in your mind before you start venturing into the mediastinum, because location of each and every lymph node and station of each and every lymph node is very, very crucial as far as staging of the patient is concerned. If you're considering a benign pathology, station 2 and 4 will not make a difference, and 10 and 2 again will be same. But in case you're thinking of a malignancy staging, localizing the node and exactly delineating which node, and every node should be sent separately in a different container or labeled in a different container to the pathologist goes, is not to mention that at all. Dr. Shyam, what are the most important lymph node characteristics you look for as far as echogenicity, necrosis, the tracheobronchial wall that you see, and all the vessels that you see beyond? Any specific characters that you look for when you are doing an EBUS? Dr. Shyam, you're muted.
So I feel as beginners, when you need to be systematic in what you document, because as you go, you need to follow a certain set of protocol where you would define, you start with the size of the lymph node, less than 1 centimeter, more than 1 centimeter, or the exact size which you can measure during an EBUS. This shape, is it oval, round? Normally the lymph nodes are ideally oval in shape. Malignant ones tend to grow in all directions, so they tend to be rounder. You need to document the margins, whether it's distinct or indistinct. Normally, they would have an indistinct margin, the normal nodes, whereas malignant ones would have distinct margins. You need to comment on the hilar or the central opacity, the central part of the lymph node, whether you have a vessel there. So normally there is a germinal center in the center of the lymph node of normal lymph nodes. It appears hyperechogenic. So if you have a hyperechogenic linear center at the center of the node, that is normal. Or if there are multiple punctate vascular lesions, or you have a central vessel over there. So these are the characteristics, and you need to see for the echogenicity, if it's a heterogeneous or a homogeneous lymph node. So usually malignant nodes, they fail to keep up, the vessels fail to keep up with the cell turnover. So you have a lot of areas of necrosis there, which gives a heterogeneous appearance. So these are the broad characteristics I would keep in mind when I document the characteristics of a lymph node in my report. So size, shape, margins, echogenicity, and the central hilar opacity or central hilar region, how it appears. And obviously the Doppler findings which you have within the lymph node. Rarely you might find this bronchial BA inflow sign, which is sometimes a contraindication to do cryobiopsy because it tends to bleed. So those are usually the broad characteristics I would keep in mind, especially when I'm starting off doing EBUSs.
Thank you, Dr. Shyam. And Dr. Anshu, among all the characters which Dr. Shyam had mentioned, what would you be kind of basically focusing on as far as differentiating between benign from malignant is concerned?
So if we look at differentiating between benign and malignant lymph nodes, I would not just look at any one single characteristic, though they do say that if you have a central necrosis sign or a central intranodal vessel sign, it's more likely to be pathological or malignant. So in combination, these signs are more useful, as we have seen, as Dr. Bala has also shown us in his slide, that when you combine all these signs together, then the sensitivity and specificity goes up. So it's not one individual sign. Also, I think when we are looking at this, if I'm doing a diagnostic EBUS and I have different stations, I can then target looking at the ultrasound, which lymph nodes I should target first, which are looking more pathological. If I see a central necrotic area, I know that the tissue from there is going to be more necrotic. So it will not be the best sample for histopath, but it will be a good sample to send for TB cultures as the yield goes up. So this is how these features actually help us during the procedure when we are looking at, identifying how to sample, what to sample. In staging EBUS for lung cancer, you have to sample anything which is more than 5 millimeters in size, and or whatever is PET avid, irrespective of the ultrasound. So no feature is going to preclude me from sampling if I have taken the patient for the procedure. And post-procedure, I can combine these findings with my histopath report as well. And if I feel that the lymph nodes were more pathological and if it is coming as reactive, I would probably want to either repeat the procedure or look at other ways of diagnosis.
The most important take home is ultrasound features are going to be helpful to kind of differentiate, but they're not the absolute last word. You have to puncture the lymph nodes in all the patients that you are suspecting a disease process to go on. And just on the basis of ultrasound characteristics, you should not be dogmatic in saying that this lymph node doesn't look good to me, I won't sample that, we can leave it aside. Any benign looking node can turn out to be malignant. And of course, you need to be, irrespective of the size of the lymph node, anything more than 5 millimeter again is going to be accessible. So make sure you target all the lymph nodes in a patient when you're doing a complete mediastinal staging. So we talked about malignancy. Dr. Bala, we see, most of us would be dealing with, tuberculosis and sarcoidosis. Any classical findings on the EBUS as to differentiate between the two, or anything which is specific for a particular etiology, for a benign etiology like TB and sarcoid?
Yeah, as we just told, to differentiate between benign and malignancy, we should not rely on the EBUS sonographic characteristics. But there is a role to differentiate between sarcoid and tuberculosis because both will show granulomas on cytology, and it may be if you do microbiological analysis for expert or smear or culture, it may or may not be positive in case of tuberculosis, and we may rely on whether necrotizing granulomas are present or caseation is present, but this may not be always there. Heterogeneous echo texture and coagulation necrosis, if present on a EBUS image, it is most likely that you are dealing with a tuberculous lymph node. There is a study done by Dr. Sajal in Chandigarh, and they found out that if you combine positive tuberculin skin testing with either heterogeneous echo texture or coagulation necrosis sign on EBUS image, it has a specificity of 98% with a positive predictive value of 91% for a diagnosis of tuberculosis. So if you have a granulomatous inflammation and you have a typical EBUS characteristics with a positive TST, you will diagnose more likely that you are dealing with a tuberculosis rather than sarcoidosis.
Yeah.
And I'm sure Dr. Sajal also has done a study on EBUS differentiation between TB and sarcoidosis. So these are the important learning lessons from that.
And Dr. Mansi, we talked about ultrasound characteristics. As far as elastography goes, how far and how much does elastography help us in differentiating benign from malignant? And does it actually help you identifying the site of puncture in a particular lymph node?
Elastography basically is a new addition to EBUS technical advancements, and what it tells us is about the stiffness of the lymph node. So what is the stiffness level? So they see that more stiffer the lymph node, the chances of it being malignant is higher, and the softer tones would denote a benign pathology, and then obviously there are intermediate levels also. So when they introduced it, it was started as a quantification which was based on visual appearance in terms of elastography, and they color coded it also. So they said that bluish tone or predominantly blue lymph node would be the most stiff, and it will be suggestive towards a malignant pathology, and then lesser shades of red and yellow will be the intermediate shades, and non-blue or typically green would denote a benign pathology. Now, most lymph nodes will have mixed pictures sometime, but again, they try to semi-quantify it further by saying that type 1 would be something which will be predominantly non-blue, and type 3 would be predominantly blue, and then type 2 will be intermediate level. So based on this, if you try to use elastography with EBUS sampling, what it can help you with is definitely not, it cannot do away with the process of sampling the lymph node. But yes, if your lymph node is predominantly, say, green, and you're trying to jab it, and with your rows, you're getting an adequate sample on the lymph node, then you can put on lesser number of passes in that lymph node, thinking that it will not be malignant probably. If you see the data which has come up for elastography, it's still in the evolution phase. But they say that, elastography does add to the number of passes that I already said, and diagnostic sensitivity, it adds up to the diagnostic sensitivity by some percentage. The overall sensitivity would be somewhere around 90%, which would be in most diseases around 80%. So using it with EBUS right now, it is still under evolution, but definitely these studies are between benign and malignant. But if you ask me about TB and sarcoid, again, there is a big problem with there, because see, I told you that it's a stiffness level of the lymph node. But if the lymph nodes are calcified or it's fibrosed, then again, benign pathologies can also actually interfere with elastography signals. And that's why it is probably not for clinical practice that much, rather than, we need more research on it, and maybe more better version of it has to come up yet. Another thing is, this is semi-quantification. There are certain objective measures like stiff area ratio and strain ratios. Again, these are under studies right now. I'm sure nobody is using them extensively in clinical practice. At least our center, we are not using it that much. We are only doing it in research setting. Yeah.
As far as literature goes, most of us would agree that elastography helps us in selecting a site. and it might lead to a shorter duration of the procedure because we'll be targeting the more, yielding areas of the lymph node, and we'll be doing less passes in a patient. But I guess there is one paper which talks about increasing the yield from 75% to 90%. I don't know where it came from, but I remember reading this one paper that says that in case you add elastography, unfortunately, we are still the old generation. I still have an ME1. I have never seen elastography at my center, but people who do it say that, there is one paper which suggests that there might be helpful in increasing the yield of EBUS in case you do elastography in each and every patient. So we know EBUS is an excellent tool to target mediastinal lymph node for staging of CA lung, for benign disorders like tuberculosis. Sarcoidosis, again, the yield is going to be between 60 to 80%, depending upon the stage of sarcoid you are targeting. Lymphoma is still a gray area, and we are kind of, we lack, and most of the patients would need to undergo a repeat procedure or maybe a surgical procedure before we diagnose them as a lymphoma of the mediastinum. So how would you, Dr. Ennis, rate the yield of EBUS, and what would you incorporate in your practice to improve the yield of EBUS as far as lymphomas are concerned?
Yeah, that's basically lymphomas has got a diagnostic challenge, not like the lung cancers, which can be easily diagnosed by a pathologist or Rose at US Center. But lymphoma, basically, you have to help your pathologist to get the real diagnosis, because sometimes the tissue you provide may be inadequate for them to do the further carrying out the flow cytometry or your molecular studies. So you need a bigger chunk of tissue for lymphomas, basically. And for that one, we can help by giving more jabs and more trying it with if you have the luxury of a biopsy, the fine needle biopsy. Or you can, if you are expertise in doing a cryo after jabbing it with a 90 needle, getting a 1.1 cryo to that lymph node and getting the cryo biopsy of the node, that also helps pathologists a lot to have a better diagnosis. But it never meets the criteria of getting knowing about the lymph node architecture as such, which they really need for a lymphoma diagnosis. And rest, we can do all this once the things are diagnosed. We can do the what you call staging or restaging, which we were talking about. Sometimes there can be challenge in the location of the lymph node, maybe more in the abdomen rather than your mediastinum. So you may have to get the lymph node from those sites. And sometimes you will have what you call you may give a false negatives sometimes. And sometimes it's it's very difficult to differentiate between this sarcoid granulomas from the lymphomas and all. So it's always a diagnostic challenge. I would, appreciate that, and you can help them out with more of technologies as well as more of tissue quantity. Later they can go ahead with the liquid biopsies or the NGS which is coming up, and we can incorporate some AA or something that maybe looking in forward with the future directions. But at present, it's always a diagnostic. It remains as a diagnostic challenge, as you have told.
So the pre-biopsy era, the yield of EBUS for lymphomas was kind of very dismal, between 30 to 50%. And neither the pathologist nor the pulmonologist was very happy with the sample that we got for diagnosis of lymphoma. With the advent of various biopsy techniques, I'm happy to say that the yield has gone up to about 70 to 80%, which is decent, but not as good as a surgical biopsy. We all, again, know that lymphoma, to kind of completely manifest in all its pathology findings, would take 6 months to 1 year. Even if you have a cervical lymph node or a supraclavicular lymph node, and you just sample it, you might not get the answer in the first go. You repeat a biopsy in, say, 6 months' time, 1 year time. So the lag period between the appearance of the lymph nodes and picking up of a lymphoma before it actually is good enough for the pathologist to categorically say that it is lymphoma, Hodgkin's, non-Hodgkin's, and the various non-Hodgkin's types would be, anyway, there will be a lag of about 6 months to 1 year. So it depends on when the patient is presenting to you and how long has the lymph node been there, how long the pathology has been in the patient to completely manifest it in the way that we understand. We are just trying to understand what nature has given us. As we understand it, there might be a delay in diagnosis, but definitely there has been a headway as far as reaching a diagnosis in lymphomas is concerned with the help of the newer needles as well as use of the lymph node biopsy for lymphomas. So coming back to the staging, Dr. Shyam, again, I would request you to come back. Very important characteristic which most of the radiologists are very keen to comment upon is the size of the lymph node. When you're talking about staging, how reliable do you think the size of the lymph node would be from deciding whether to or whether to not access this particular lymph node?
So I sample, irrespective if the lymph node is visible, I sample it. Because staging, you need to, it depends. I mean, if you have, the bottom line is you should sample every node which you can localize with an EBUS if it's for staging. But if it's for a condition where, like you had mentioned, if it's a fluid overload condition, or a liver disease, heart failure, there you have a large node, probably you wouldn't sample. Or if the duration of the illness, if it's like an infection, there a short duration, probably 4-5 days, and then you see a lymph node, you probably wouldn't sample that. But staging is a different ball game. Even they say, even non-PET avid lymph nodes, non-FDG avid lymph nodes, sub-centimeter, it's wise to sample them because they sometimes increase the yield and they can surprise you with
10% of them would turn out to be positive. So
yes.
we rather not ignore this number.
Yes. So there's a nice study published. So Pawan Anshu she's part of the study, I guess, where they actually published a paper on non-FDG sampling non-FDG avid lymph nodes in cases of malignancies and in staging especially. And it was actually a positive study where they actually showed that sampling even non-FDG avid lymph nodes is quite crucial in staging.
So goes without saying that irrespective of the size, in case you are thinking of malignancy and you're doing the basic purpose of doing an EBUS is a staging mediastinal staging of the CA lung, then make sure each and every lymph node in the mediastinum, irrespective of the size of the lymph node, anything which is visible should be punctured and taken care of. And of course, the order has to be from N3, N2 to N1. We'll be covering all this in the subsequent lectures that we're going to have. There were a couple of questions about sequence and everything, but I think let us now focus today primarily on the anatomy, the ultrasound, the characteristics, and of course, we'll be talking about needles in the next few questions as well. Dr. Anshu, how would you access a supraclavicular lymph node with an EBUS? A very, very, very exciting era. Very, very exciting to me, in fact, when I read about that papers about it. And is it actually useful? Why would you need you could rather have a cavity and ultrasound, everybody would have it with us as pulmonologists. Why would you need a miniature ultrasound EBUS scope to do a supraclavicular FNAC?
So actually, sir, you are very correct. It's a clinically palpable node. I remember during our postgraduate training days, we would do the clinical palpation in the OPD and then do the FNAC right there.
Exactly. You never needed an ultrasound.
Yeah, we never really needed. Nowadays, in the era of molecular markers, we send them for ultrasound guided biopsies because you need bigger tissue, and also it's a local anesthesia procedure which is done without any very few complications. So we would not really be doing EBUS for supraclavicular lymph nodes. I have never done it. Technically, yes, it is possible if you look just below the supraglottic from the trachea to the right or the left. If they are big enough, you may see it, but I have never sampled.
No, in fact, there are now papers talking about what you're talking is inside the trachea. You actually finish the procedure, you expose the supraclavicular area, and the ultrasound like this. There are papers like that too. And one of the assistants, rather than using the trachea, one of the assistants would just hold the scope like this, and the other person would look on the, and you would actually puncture it with an EBUS needle. So rather than going through the trachea, of course, the supraclavicular and the nodes are going to be away from the trachea.
Yeah.
Rarely would they be adjacent to the trachea.
Yeah.
But now there are papers the literature is expanding, it might not have any clinical utility, but people have their own ways of doing things. And there are now papers in which, you have an ultrasound EBUS probe like this, one of the assistants is holding and the operator is dabbing. So it seems funny. It seems funny, but literature, these are published series, not case reports. There are published series now talking about a supraclavicular FNAC done through an external EBUS. It is not an endobronchial ultrasound. It is an external ultrasound using the miniature EBUS probe. So exciting times ahead, I must say.
We are all learning new things every day.
Sorry?
We
Come
are all
again, sorry.
learning new things every day.
Oh, yes, you would be doing parotids and inguinals also using EBUS now.
Amit, now our EBUS will be taken away for all axillary and inguinal lymph node by FNACs even.
Exactly. So
Don't tell it in a loud voice.
Go through it.
Yeah.
There are papers about it. There are videos and there are depictions showing people using an EBUS scope externally to do an FNAC with an EBUS needle.
Yeah.
So, let's see how far we can venture. Now, people have been taking our job away from, radiologists have been taking our job away from us. We would rather venture into their territory as well now. So, Dr. Bala, are you there? I think Dr. Bala is taking rest. Yeah, Dr. Bala, good to see you. We were having some very interesting conversation about doing a supraclavicular lymph node.
Yeah, that's right.
I came across a couple of papers. It sounds very funny. But,
it is described. Yeah, I agree.
Yes, it is. There are papers describing your supraclavicular as well. So when you talked about you very lucidly you talked about the location and the anatomy of the lymph node. Apart from that, how does the lymph node fare as far as telling us about bronchial invasion or a vascular invasion? So what are the characteristics of the ultrasound which tell us about the invasion rather than, and how do you compare it with CT or a PET?
So a lymph node is considered to be invasive if the margins are indistinct and blurred. You can't make the full margins made out on an EBUS image. If you can make the full margins, it is likely that it has confined itself to the capsule of the lymph node and it has not spread beyond that. Similarly, if there is a coalescence of adjacent lymph nodes, then we say that it is likely that the lymph node has spread to the adjacent structures. So this is one way we can consider use EBUS to find out whether it is likely to be spread out beyond the confines of the lymph node or not. To see whether it has reached the lesion has invaded the airways, probably you should use the radial EBUS, because radial EBUS, it is a high frequency and the resolution is much more, and you can even delineate the various layers of the bronchial or the tracheal epithelium. And then you will be in a better position to see whether it has invaded the layers of the tracheal wall. So the margins and the coalescence as well as
in case the invasion of cartilage is there and you have anything in the trachea or the first 2 centimeters, again it becomes inoperable. So as far as ultrasound is concerned, many times a CT or a PET will not be clearly giving us the invasion of the tracheal or the bronchial wall, and sometimes in hilar or an area where you have the aorta and the pulmonary artery, in the station 5 and station 6 lymph nodes, the invasion of the vessel is not very clearly seen on the CT, but ultrasound will be actually able to help us in a better way as far as delineating the invasion is concerned. Another very important aspect which we kind of look to as far as invasion is concerned, we get referrals for invasion of the tracheal wall in the case of CA esophagus. So conventionally, the gastro people just asked us to do a bronchoscopy, and in case we do not see any visible signs, we are very happy. But now after doing a bronchoscopy, that is a white light bronchoscopy, we are doing an EBUS in each and every case of a CA esophagus coming to us for any sort of a tracheal invasion. And what we find is if you position the EBUS posterior, on the posterior wall of the trachea, and you do not see a good slide, there might not be anything as far as visible, marker of invasion. But in case you do not see a good slide of the esophagus under the posterior tracheal wall, it is a very good sign of invasion. And of course, CT or MRI will be able to pick it up. But as far as CT is concerned, I am not very happy with the tracheal wall invasion by a CA esophagus. So the bronchial or the tracheal wall invasion, vascular invasion, the indistinct margins of the lymph nodes, and the invasion of the posterior tracheal wall in a CA esophagus would be the most important thing which you look for as far as the infiltration of the lymph node into the adjacent structures is concerned. We have some paucity of time. We have a couple of questions on the access of station 2 and station 4, station 7, station 10 and 11. We can talk about needles first because we have not talked. That was the third part of our, agenda for today. So let's devote about 10 minutes to various types of needles and the techniques, and then we can come back to the specific locations of these stations of lymph nodes. So Dr. Anshu, what are the types of EBUS needles available today? And in your practice, how would you rate them as far as their utility is concerned?
So when we look at EBUS needles, you have the fine aspiration needles, which are the ones most commonly used, and they come in different sizes from 19 gauge, 21 gauge, 22 gauge, and 25 gauge as well. They are made different companies. There are 3 main companies in the market, and they are made from different materials. So you may have it as stainless steel, nitinol, cobalt chromium, cobalt chromium. So, and when we look at this, most commonly we use 21 and 22 gauge needles. If you look at literature, there are various studies. Some studies will say that 19 gauge is better. Some will say that actually it is giving you the same yield. Also, one of the important things is that the newer versions of the needles which have now come on the market, they are more flexible. So whenever we put a needle into the EBUS scope, what we notice is that the flexion of the EBUS scope gets reduced. It is because of the stiffness of the needle. However, with the newer generation, so if the EBUS scope can flex up to 90 degrees upwards, we are getting up to 85 to 80 degrees flexion while putting the needle in with 19 gauge needles also. So the newer needles have that thing, and also they are have good safety mechanisms to prevent damage to the EBUS scope as well. If we talk about the EBUS fine needle biopsies, so you have needles which have different changes made to the stellate, which is the puncture site of the needle. And what you note, you have the ones which is the Procore, which comes by the Cook Medical, which has a little bit of a bevel tip and a core trap at the end to get the more sample. And then you have this crown cut where there are 3 crown-like structures surrounding at the needle. So you're getting more core samples. They are the Acquire and the Mediglobe version is also there. However, it's not available in India. So you have these biopsy needles. There are some studies that in cases like sarcoidosis and lymphoma, they give a better yield as they are able to generate more core tissue as compared to just the normal aspiration needles. For us, in lung cancer staging, we find that 21 or 22 gauge needle gives you very good results with very good sensitivity and specificity.
Thank you, Anshu. And I see Amita has joined us. Amita, how are you? Okay, we can, Amita, if you're there. I just saw you on the screen. So moving on to Dr. Bala again, we have 19, 21, 22, 25. How would you rate performance of each of these needles as far as their yield and the amount of blood that you... Hi, Amita, nice to see you. So how do you rate the 19, 21, and 22 and 25 as far as the yield is concerned and the amount of blood that you see on the smear?
Just as Granshu has told, the most commonly used needles are 21 and 22.
Calling me. Hi, Amita.
So usually what all of us commonly use is 21 and 22. But in case we are not getting adequate samples, grossly you smear it, nothing is coming, you try to take a clot specimen or but nothing is coming, then you try to use the 19 gauge needle. The puncture with the 19 gauge needle may be difficult and it can be more bloody, but it should be the next line of sampling if the initial sample with the 21 or 22 is not giving you adequate samples, either grossly or by rows. Studies have compared two arms with a varied result. And a couple of years back, we looked at the yield in the EBUS India guidelines, which was published. And we found out that when we pulled all the results of comparing various needle sizes, didn't make much of a difference. For a given patient, you start with the standard needle size and you go for 19 gauge. In case you feel that your sample is not adequate, you need more tissue for confirmation, especially if you are thinking of things like lymphoma. But now that the biopsy has come into the picture, that has added a new dimension. Instead of going for the 19 gauge, relying on the 19 gauge, you use the 19 gauge to make a puncture, and then you introduce the forceps or the cryo to take the samples. That's the plan which we do it nowadays. We use 19 gauge basically to make a track to put the biopsy forceps or to put the cryo probe. So that's the usual protocol which we follow nowadays.
Thank you, Bala. And coming to another very controversial topic, all these needles which we get from various manufacturers are labeled as single use. But the cost is again prohibitive, and most of us would be reusing the needles. I would just need Dr. Enes to kind of take us through single use versus multiple use. And rather than talking about your own experience, I would rely more on the guidelines and the papers which we have put in, and of course the guidelines by the IAB. So let us give a very clear message to the audience without being controversial as to single-use needles versus multiple use of these needles.
Yeah, thanks, Dr. Amit. It's basically if you are luxurious enough to have a single use, I would prefer that, because it actually doesn't make any cross contamination, first of all, and from intranodal jabbing, and then it may be of, as you have told, it may be of very costly to use single use in single node. It will be especially for staging cancers, and then if you use single use, there is the sterilization and the reprocessing doesn't make any sense for those things, right? And that way you can save some money, and then it will be a medical waste if you use single use needles everywhere and then every node and then discard it off. Then it will be a huge hospital medical waste, because there are a lot of centers right now doing the EBUS, and each needle for each node will be very, we are not a highly developed country for using that kind of. So to take off these problems, usually while staging only, the issue of cross contamination comes. So what I used to do is I used use single use multiple times, but for a staging I start from N3 and then go to N2 and then N1, so that if the higher node is positive, I stop over there, because it's anyway, if N3 is positive, you need not go to the N2 and then sample it, because the stage becomes very clear. And then what else you can tell? Preferably, if you have single use and you are luxurious enough, the insurance is paying the patient, then better you ideally theoretically you go ahead with the single use. Otherwise, most of the Indians, what we do is we use multiple use with the single needles. But you should be very stringent in reprocessing or sterilization techniques. And you have to be careful about the needle tip damage or the dullness which can occur after multiple jabs. And also be careful about the cross contamination of within the patient, and if you're taking it out to the next patient. So that's only what I can give you the guide.
And Dr. Mansi, what are the guidelines? What do the guidelines say as far as single use versus multiple use? Do we have any papers,
So there is one study which has been published from PGR research regarding single use versus reuse of the needles. And they did it was basically a retrospective observational study in 500 odd patients. And 350 of them, they used new needles, and 150 they had to reuse the needles. So they found out that primarily the population was chronic granulomatous condition. They found out that the yield was not dependent on the single or the reuse potential of the needle, but still they said that if possible you should try, because the process of sterilization they were using glutaraldehyde, and they also subjected the needles to ethylene dioxide. Then only they could reuse the needle. So that process also has been. So the recommendation as per IAB guidelines says that there is no change in the diagnostic yield. If you don't have an option, you should go for a reuse. But if you have the option, the patient opts for it, then probably you should use the needle single time.
So very rightly said, all these products are single use. In case we are reusing, we have to be very, very stringent as far as decontamination and sterilization process is concerned. And there should be nothing lacking from our side to compromise the safety of the patient. As far as safety of the patient, that is first and foremost. In case we are in a setup and our technicians and our setup is not geared up for re-sterilization of the needles in the way it should be done, we should not be using them at all. But in case we are using all the precautions, and the costs again are going to be prohibitive if we use single-use needles in all the patients. Many patients would not be able to afford the procedure, in fact, in case we go for single use. So make sure that you have sterilization process intact, and each and every member of the team is well versed with it, so that there is no compromise as far as the safety of the patient. And whenever you feel that the needle tip is blunt, blunt enough to make the penetration or the puncture of the bronchial or the tracheal wall difficult, I would suggest that you kind of discard these needles and subsequently do not use them again. So you have to be very clear when you're using a reused, re-sterilized needle. The sterilization process has to be stringent, up to the mark, and there should be least, complications as far as the patients are concerned. So how many needle passes per lymph nodes, would you do, Dr. Shyam, for a good sample and a very good yield in your center?
So provided you don't have rows in your facility, what the guidelines say is should at least take 3 passes per lymph node.
All this is without rows. If you have rows, you can do with one as well.
Yeah, I can stop it
without rows.
Without rows. So without rows, 3 passes at least each node, be it for staging, be it for diagnosis. If you want to send additional molecular profiling, you need to keep an additional sample, or even if you're taking samples, if you're suspecting lymphoma, you need to do extra molecular profiling, then you need to take 4 passes. But sometimes you might not get adequate, samples even with 4 passes. Then obviously you have to improvise. It's not etched in stone that you need to take only 4 passes. This is at least 4 passes, but you need to make sure that you get a good sample at the end of each procedure you do.
So after doing a couple of procedures and preparing your slide yourself and seeing it under the microscope, you'll be able to understand which smear is good. In case you get a granular smear, in case you're thinking of a benign pathology or a malignant pathology, in case you get a necrotic smear when you are suspecting tuberculosis, you're very happy you can do with just 1 or 2. It all depends on the quality of the smear that you get. If it just spreads like peripheral blood film, you have a smooth stroke, and you see only blood. You do not see any granularity. Of course, you need to discard that sample and do some more passes. So looking at the naked eye appearance of the slide and the p-test probability of being a malignant or a benign or a tubercular pathology as far as necrosis is concerned, if you see that, you'll be able to select whether to stop at 2 or even go up to 7 or 8 passes in certain cases, in case you are suspecting a lymphoma or a sarcoid. 3 is not, gospel truths. 3 is just a number. They've seen that in cases of malignancy, in case you take 1, 2, or 3 samples, the yield goes up significantly till 3 samples. After 3 samples, it plateaus. But in our country, the situation is very, very different. We still do not have papers talking about number of samples as far as sarcoidosis is concerned. So the number of 3 comes from papers which talk about the staging procedures and not a diagnostic, undiagnosed mediastinal pathology. So it depends on your expertise, whether you have, rows alongside, and of course, how qualified or how confident you are looking at your own slides under the microscope, which will determine the number of passes in a particular node. And how many jabs, Dr. Anshu, would you do per node, just to take the question forward, take this thing forward from Dr. Sham?
Yeah, so normally we perform anywhere between 10 to 20 jabs. That generates enough capillary suction and also gives enough tissue inside. If you do excessive number of jabs, you tend to get a more bloody sample.
Bloody sample.
Yeah, so I think up to 20 is a good number to do. Beyond that, only if you're not getting any yield while you're looking at your slides or when you're trying to get the sample in this, you can go up to 30, but normally we restrict between 15 to 20 jabs per pass.
So I guess if all of us are not very tired, shall we just take 10 minutes questions from the audience as well?
Yeah.
I would.
Yeah.
All of us agree to that?
Yes.
So I'll just
Yes,
read
yeah.
out whatever they're all on my screen. In case they are relevant, I'll be talking about them. So we have more than 2,000 logins. Cheers to all of us. We're doing a good job. Okay, we talked about how do you integrate EBUS findings with other diagnostic modalities like CT and PET. We've taken care of it. What are the common challenges accessing lymph nodes during EBUS? So this question is open to the house. Anybody who would like to volunteer. What are the common challenges accessing lymph nodes during EBUS? Or a particular station in case you find them difficult in your practice?
So I'll go first. So
Yeah.
first of all, if not just accessing nodes, if the patient is coughing a lot, if you're doing it under conscious sedation, not under LMA, patient is coughing a lot, he's one of those where, even topical lidocaine is not working, that is definitely a challenge. The second is in stations, for example, 4-hour or 2-hour, where if you're not quite adept at using the balloon, then you might find it challenging, getting the correct opposition to the walls. 4L is usually slightly challenging sometimes.
Yes.
So that is why, because you need to flex the scope a lot. So that is why certain centers who are comfortable doing EUS, they would recommend sampling the 4L node through EUSB rather than an EBUS. So these are the common challenges I would which are there in the top of my head as of now.
And
Another thing I'd like to mention
please,
is that
Dr.
certain lymph nodes are very difficult to jab because of the calcifications and fibrosis.
Yes.
So it is a good idea that to look at the sonographic characteristics and try, because if the lymph node is big, you can definitely find a good site to jab your needle into it, avoiding the vascular part and avoiding the calcified part inside it.
And what are the limitations of EBUS in lymph node staging? How often would you be kind of missing a diagnosis?
So if you're talking about lung cancer staging, what we know is that negative predictive value of EBUS is more than 95%. So if you look at the ASTER trial and the MIDAS trial, you would have to actually do 15 to 16 mediastinoscopies to pick up one occult N2 which got missed by EBUS. So normally a lot of centers which are high volume oncology centers, they would go with EBUS as the first step for mediastinal staging. If it is negative, only in suspicious cases where you have a discordance between your USG findings and your histopath report, would they subject the patient to mediastinoscopy, as it can be done immediately in the same setting, as they can send a frozen And if it is negative, they can then proceed with the lobectomy or whatever surgical resection is planned. However, it does have a very high sensitivity, specificity, and if you add EUSB FNA to the picture, then you are accessing all the lymph node stations actually, which is not even possible by mediastinoscopy.
Very, very rightly said. So we're all bothered about the complications of the procedure. One question just came up. What are the potential complications? I would not say complications. Any misadventures with the needle you people have faced?
Broken needle inside the trachea.
Yeah,
I've
please
seen
go
one.
ahead, all of you. We all have had certain instances.
Needle bent needle and broken needle I've seen. So that is one of the biggest nightmares that I had because it was difficult.
Was
So
it
I didn't
a
feel those
standard
things.
Olympus needle or a local Indian?
The biggest problem was once the needle was bent, how to put it back in the scope and come
Yeah.
out of the trachea. Also, you were bothered about the scope then, rather than the patient per se. So that was quite challenging.
And
That is a thing. I don't see much complications otherwise in a smooth procedure, but this is something like a technical part. Like the needle, and in very stiff nodes, sometimes the sheath is moving along with the node, and when you're trying to jab. So when you're trying to hit too hard, that is the time when your needle gets bent. So I think that maybe somebody else would like to share their experience on bent needles. But yeah, we have had a lot of experience on bent
some
needles,
bend
especially
needles, yes.
treated patients. Yeah, treated patients with radiotherapy, and like Anshu has already said about it.
Yeah,
Those bending goes after multiple use, right, Mansi? Or multiple use of things makes the bending, no?
No, sir. Actually, in our center, we don't use multiple needles. We are not using needles multiple times. So this is in patients, so patient specific. Like the lymph nodes were only hard and stiff. Probably because they were treated cases of extrathoracic malignancies, or maybe they were treated cases of tuberculosis having a lot of calcifications, and then we were suspecting maybe some additional pathology. But they were difficult to jab otherwise. We've made videos of it, and we're not able to jab at all.
Yeah, that's a indication for change. For me, I use multiple uses with the same needle in multiple nodes. So that's one indication where you are not able to jab the wall or the nodal periphery. That's an indication to change that needle. That's the end of that life of that needle. We have to get a new one, and that usually enters smoothly. So the new one. So that's the indication to discard that needle. But if you are using multiple times, I use sometimes. That's all.
So one question about rare infections and opportunistic infections that you see doing an EBUS. Now, what all have we encountered? Fungus, nocardia, histoplasmosis,
NTM.
and NTMs, of course, not unusual. You would have TB, and NTMs are abundant in our country. But anything else you would like to share?
Yeah, so I just presented a paper, this ERS, on atypical fungal infections diagnosed via EBUS. So it's basically, the bottom line was not all granulomas you get need to be TB.
Tubercular, yeah, of course.
So there was this interesting case where they diagnosed this patient with sarcoidosis on the basis, or sarcoid/TB on the basis of just granulomas, but gene expert, everything was negative. They finally decided to treat him as sarcoidosis, gave a course of steroids. He developed intestinal perforation, had to go resection anastomosis. Even the resected sample of the intestine did not test positive for TB. Then they put him on methotrexate, assuming it was still sarcoid. Then came to us because he couldn't tolerate methotrexate as well. But then so apart from big lymph nodes, which was actually bigger in size, he developed a little altered sensorium, found that, he had lesions in his brain as well. And so we did EBUS, we took some cryobiopsies, we found histoplasmosis, and even the CSF tap showed histoplasmosis. So
we've had instances of TB and fungus together in a post-transplant patient. Milioidosis we picked up in lymph nodes, abundant in our part of the country again. So the list is kind of ever expanding, and anything which the microbiology, in fact, it doesn't credit us. We should not credit ourselves in, it's the microbiologists who kind of pick it up for us. We do the procedures similarly in all the patients, irrespective of the diagnosis. So, of course, microbiologists, big clap for microbiologists to pick up these rare infections for us. What are the significant size? Of course, we have taken care of. Water balloon, we have talked about implications of station 11 involvement. Okay, minimum training period required to practice, EBUS. Any one of you?
Yeah, I would tell like the candidate should be assisting you for around 50 or 40 or 50 procedures,
Okay.
and then let them do the procedure with your supervision, and then only they can perform around 40-50 again, and then only they can perform after crossing around 80 or 100 procedure.
All right.
But ERS, I think the ERS says 40. I am not sure, but what I feel is my place is where we have the MD respiratory as well as DM pulmonology candidates. They have to be with me for the procedure at least 40 or 50. Then only I give them the hand, and then they perform, and I will be assisting them, and then only they are made to do the procedure. Around that makes like around 80 to 100 procedures. Then only they can do alone.
So first supervising, and then under supervised guidance doing the procedure, and then only you're competent enough to, I think, undergo or do a procedure yourself. Any instances of injury to recurrent laryngeal nerve during lymph node sampling? Any one of you has had any instance or literature talks about it? I'm not aware of it. None, I guess. Okay. Okay, N3, N2, N1 we've discussed. Mickey Mouse sign, station-wise guide map, of course we'll do it. So there's some books on EBUS. Yeah, so there's some books on EBUS.
Specifically for EBUS, I'm not
Yeah.
sure, but there are many books otherwise.
Yeah.
Bala can write one.
We all
Dr.
can work
Malay
on
Sharma
it.
has written 2 articles, one on
Yeah.
EBUS,
They are
lymph node
exhaustive.
stations,
They are exhaustive.
and endoscopic ultrasound. So I will recommend, if you want to know details regarding anatomical landmarks, Dr. Malay Sharma's article on that you can read.
When most of us belong to the era when there were no books on EBUS at all. So
Yeah, that's right.
for younger generation, of course, we need to do something about it. Yeah, Dr. Anshu.
Yeah, so there are a lot of good videos on AABIP
Yeah.
on YouTube where they show each lymph node station sampling both the endoscopic and the ultrasound characteristics, and it is station wise. So I think that's a good resource for beginners to actually look at those videos again and again to understand that.
I guess the only
Yes.
book I read was when I went to Tokyo and I was given this book from the Olympus Center. It was by Nakaima and Yasufuku. It was an excellent compilation of, staging. Of course, this was way back in 2010. It was in infancy. Things have evolved significantly since then, but that is the only book I remember reading as far as EBUS is concerned.
Amit, can I say
We have
something?
Amita. Oh, hi. Good to
Amita,
see you. Good to
hi,
see you, Amita. How are you?
I'm very good. How are you? You all
All
have been
fine,
doing a
all
fantastic job. I'm very happy to tell you all we have 2,053 live logins right now.
Oh,
And
wow.
we've had
Great.
57 questions. I just came in to answer this question about the book. So there's a fantastic book on endobronchial ultrasound by Ernst and Felix. So I
Okay.
would basically recommend all the students should definitely go this. I mean, read it. And I feel that every book who's doing, every hospital which is MD or DNB, the library should have it. Fantastic book. I mean, I would really recommend it.
Thank you, Amita. Thank you for the comments. And I think we are touching 10:30 now, and we
I
all
think,
of us have had a long, all of us have had
the
a long working day.
actually,
So
the thing is that the tech team just messaged that all 2053 are still logged in.
I know
If
I
you all
have a
want to
long
take
list
4,
of
5,
questions, but I think if I
okay.
start going through all of them, it'll take another
Okay.
1 hour for us to finish.
Sure, whatever. So if you want to take 2, 3 more questions, fine. Or we can wind up. That's totally okay. You all
I
can
think
decide.
10:30. I think let's stick to 10:30 as the deadline.
Okay, great.
Time for us to wind up. We have had a wonderful session. Excellent talk by Bala, and of course, very exhaustive. He's a thorough, teacher. I understand that, and all of us have had chance to learn from you. An excellent panel, very learned panel, where very well read, and most importantly, very well experienced. All of them have done the procedure n number of times to kind of go through it without reading any literature about it at all. And I thank you, Amita and IAB, for this opportunity. And I guess we also learned a lot from this. And I hope the audience has had a wonderful session, and we hope everybody gained something out of it and would be going back home wiser after this session. Thank you so much.
Thank you so much, everybody. Dr. Bala, we are getting fantastic reviews about your talk. I think it was really a state of the art. Everybody must hear this talk. Amit, you were outstanding.
And everybody must know how to make slides from him. I'm really impressed.
We just have to take his slides, period. We just ask him for his talk.
Yes.
That's what we do.
All the animation, of course, I'm still very poor at, which I should learn from Bala.
Amit, I'd like to say, you were outstanding, as the moderator. You just made sure the discussion was so crisp. It was so interesting. You made sure everybody was to the point, and you really brought out the best from everybody. And I'd like to talk about each of our panelists, because I just feel that every panelist of ours, huge big thank you to each of y'all, because each of y'all deserve to be the speaker and the moderator. And despite that, y'all agreed to be the panelists. So we are just so happy. And I just want to say that everybody was phenomenal. We know Dr. Ennis, how much work he does, what a passionate teacher he is. And everything was just being reflected, all his passion, etc. Mansi, I think she's the girl who's done maximum EBUSs in India. And I keep on telling her, I keep on calling her the EBUS lady of, amongst the women, I'm saying she must have done maximum EBUSs amongst women in India. I keep on calling her the EBUS lady of India. And it was very, very nice to listen to what she was saying. And in particular, I love to hear that she said that in their institute, they don't need to repeat or reuse needles. I think it's really luxury. And I think it was very, very good listening to you, Mansi. Shyam, as always, you make us proud. You really make us extremely proud. Talking with a sweet smile, with a lot of confidence and great information. And Anshu, of course, we are so proud of you. You are our Bombay girl. You are our Bombay girl who does more IP than any of us. Always keeps a low profile, always keeps on smiling, but words of wisdom always come out. So a huge big thank you to each of y'all. And I think 2053 is a huge number. A big thank you to our delegates for being logged in for more than 2 hours. I'm sure they are hungry. And so many questions have come. What we'll do is we'll try to send back answers to our, because we have the email addresses. So we'll just send back answers which we couldn't. And a very big thank you to our partners, Mankind and Olympus. Especially from Mankind, I'd like to really thank Nitin very, very much for helping us so much, and our tech team, of course. So I think with this, we can end the webinar. I'd like to say our next webinar is after 2 weeks on 4th of October. And this webinar is also going to be extremely exciting because it is all going to be about linear EBUS step by step. So it's going to be full of videos, full of information. So thank you so much. I think we can stop now.
Thank you.
Thank you all and good night.
Thank you.
Good night. Bye.
Good night.
Bye,
Good night.
everyone.
Bye. Thank you.
Bye.